Everyone, and as you know, today is the last session of the teaching program. The topic for today's discussion is pain management at end of life care, and the learning objectives of this session will be recognize the dying process, to describe when it is appropriate to withhold treatment, and prescribing for end of life care. The today's session will be covered by the faculty, Dr. Sanghamitra Bora. She has already taken a session for us. This is her second session. So most of you will be knowing her. And for those who haven't attended the last session, I'll just give a brief introduction. She is a lead palliative care of Assam Cancer Care Foundation. She did her MSc Palliative Medicine from Cardiff University, UK, and she's the honorary director of Arjun Healthcare Foundation. She's an active IAPC national faculty, and she's a national trainer for National Health System Resource Center with Government of India. She's a very active member of various palliative organizations, and she's a close friend of palliative Pallium India Trivandrum. So we welcome you again, ma'am, to this session, and over to you, ma'am.
Thank you, Rajlakshmi, and thank you, Manu, Dr. Manu. It's a great pleasure, as usual, to be with a teaching program facilitated by Pallium India, and it's always important that we learn new things every day. And I can actually say that I've been taking few classes for Pallium, and I have been relearning many things in this process. So thank you very much for having me. So we are going to discuss about the end of life care, and specifically, talk about pain management and other issues. But I would like to say that it's a huge subject in itself, and while I was preparing my presentation pertaining to the guidelines given by Pallium, I thought it is also important that I include some of the some important points that need to be discussed, so that when you take back the message today, you don't feel that there's something lacking in it. So I apologize if I overshoot the time, but I hope that you'll definitely enjoy the learning process today. So is my screen available? Visible to everyone?
Yes, ma'am. Slideshow would be good.
Yes. Yeah, is that okay?
Perfect, ma'am.
Yeah, okay. So I have divided this whole presentation into three processes, basically, pertaining to what the primary oncology team or the provider does, the process being the end of life care, and the ultimate outcome that we all are desiring is a good death for our dying patients. Since we are discussing end of life care, we have accepted that after doing everything for our patient is actually leaving this world. And as a healthcare provider, as a primary oncology team, as a palliative care team, the most important thing that we need to ensure is a good death for our patients. So I'll come one by one to all the three important pillars of this structure. So I want to discuss this in three settings. Firstly, discussing about good death, basically going on to what is a good death and what are the components of a good death, and who would be the stakeholders. Proceeding to the process, which is the end of life care, and basically explaining to you about a 12-step pathway of EOLC, the principles that govern the end of life symptom managements, little bit about clinically assisted nutrition and hydration at the end of life, and palliative sedation also. So at last, I would actually discuss, not exactly discuss, I want to show you something regarding the attitude and communication of the provider or the oncology team or the palliative care team that actually goes through along with the patient the process of end of life care and gives the patient a good death. So coming to the outcome, so I would like to have some little responses from every one of you, if possible. So this is a story of Mr. AB, who is a 66-year-old man with lung cancer. His cancer spread to his liver and bones. He has been experiencing severe back pain and pain in the right upper side of the abdomen. He is unable to sleep, he is worried, he is distressed. He has little or no information about his illness and is not also aware of his prognosis. So he has been receiving chemotherapy, and his family is now wanting to continue with the chemotherapy. He has no say in this particular decision at all. 2 days ago, in the middle, he was brought to the hospital with increased breathlessness. Now, in the hospital, the family actually wants all the intensive care measures to be done for this patient, including intubation and ventilation. Unfortunately, he died in the ICU on the ventilator, and he received 2 cycles of CPR also during his death. Now, my question is, what is your take on the way that Mr. AB has died? And what could have been done differently if you feel that something could have been done differently than the way that he has died? And thirdly, how could your decisions, I mean, your take on Mr. AB's death would be brought about, the changes that you would want? So just 2 or 3 responses, quick responses, if I can get. You can also post it in the chat box. Yeah. Any responses?
No responses yet, ma'am. Can someone unmute and tell the answer?
Yeah, just I need 1 or 2 responses so that we can just proceed. Okay.
Okay,
Ma'am,
ma'am. Just a response from
Dr. Gopi here.
Yes, Dr. Gopi, please.
Ma'am, first of all, the patient has all the right to be informed about the case, and he has the right to take on the decision. So that would be the first point that I would like to point out. Secondly, it's a progressive disease with a lot of pain to the patient. In this stage, the ICU admission would again increase the suffering of the patient. So ICU shift could have been avoided. And again, the patient's bystander should have been properly informed about the condition, about the prognosis of the patient, and the problems of again continuing him on intubation and allowing for a CPR, because it again increases suffering of the patient. So a proper communication before sending them and during the treatment should have been done to avoid this status.
Absolutely, absolutely. I completely agree with what you've said, Dr. Gopi, and thank you so much for this response. Dr. Ravi Kiran has also actually posted about patients' preference not taken, warning shot from the oncologist to the family was not done, communication error from healthcare providers and family. Thank you so much for these responses. So absolutely right. So actually what would be a good death, as we have been talking now. We need to know when death is coming and to understand what can be expected. Also to be able to retain control of what's happening, and the patient to be given the dignity and privacy that he deserves, and to have a control over pain relief and other symptoms that are coming at the end of life, to have a choice and control over where the death is occurring. So as you had seen, Mr. AB actually very unfortunately died inside the ICU. Whereas, research actually suggests that 90% of patients, which also includes me, if I'm asked, that I would like to die at home. So there has to be a choice and control over where death occurs. Very importantly, the patient needs to have information and expertise of whatever kind that is necessary at that particular point of time, to have wishes respected, to have access to any special needs, to have control over who is present and who shares that particular end, and to be able to leave when it is time to go, and not to have life prolonged pointlessly. So unfortunately, Mr. AB, didn't have much of this. So actually, we can actually conclude that he really didn't have a good death. So that brings us to, the components of good death. Basically 6 components, where again, there has to be a control of current pain and symptoms, physical symptoms, along with a reassurance that in the future also these symptoms would be promptly managed. There has to be a communication about clear decision making, and the families or the caregivers will need to be empowered so that they are able to take decisions on behalf of the patient if the patient is not able to do so. We have, as a team, we need to help patients to know what they could expect during the course of their illness, and then, uh, in that way, help them to plan for events that would follow after their death. Now, many a time there are, there is a mention of death cafes, in the literature. I don't know whether this is applicable for India, but in the Western world, there is something called the Death Cafe, where people actually talk about death, how they would like to die, what are the things that they would like to fulfill. Coming on to completion, which is also a very good component of good death, which means that there has to be meaningfulness at the end of life, and dealing with faith issues, review of the life, and resolving conflicts if there are any. People would like to contribute at the during the last days of their life. So it is our moral duty to make some kind of provisions for the terminally ill patients so that they can contribute for the well-being of the others. Last but not the least, affirmation of the whole person, which involves the patient being affirmed as a unique and a whole person, and not understanding the patient from the disease perspective, but also in the context of their lives, their values, and their preferences. So this brings us to the actual subject that we're talking about, which is the process of how to give a good death to our patients, and that is end of life care. For a proper end of life care to be executed, there is a 12-step pathway that has been laid down, and this is actually now validated. If you can see, the step 1 actually starts with the physician's assessment of utility, where the physician is actually concerned about whether the interventions that are intended for cure of the patient has now become futile. And there are many such instances where there is a difficulty in understanding the futility of an intervention, and our patients are unfortunately subjected to a never-ending futile interventions, which should not happen. So the physician needs to do a scientific assessment of futility. Second step would be to take a consensus of his team or the consensus of the healthcare providers that are in and around him. In a palliative care setup, we also inform or take the consensus of the extended multidisciplinary people, for example, the radiation oncologist or the anesthetist, the pain specialist, so that we can all come up to one decision that as of now, the interventions that were intended to cure the patient have actually become futile. The third step is disclosure of prognosis, because once you've reached a consensus that the interventions are becoming futile, that actually means that the prognosis of this patient is not going to be good. So you need to disclose this particular point to the patient as well as the caregivers or the family. This needs a lot of communication skills, and you need to start with communicating the initiation of end of life care from this particular point, from the fourth step. So when you have actually have had a consensus of your team, of your extended multidisciplinary team, you have to disclose the prognosis of a bad prognosis to the caregivers and also to the patient, and then communicate that you are now going to shift your care totally intended towards giving an end of life care. Now, this particular stage, you slowly shift on to a shared decision making, because this is a kind of a transition that happens from the intention of cure to an intention of complete palliation, where the palliation would actually take a very important and a larger chunk of all your work, all the work that is done by your team, all the work that is done by the multidisciplinary team also. So at this point of time, you have to have a shared decision making. You have to give a shared decision so that everybody actually comes to a point of agreement that yes, this is the next step that everyone has agreed, including the patient, the caregivers, and the clinical team. Now, coming on to when you have actually taken a decision, you actually now do a complete documentation of the process. So whatever you have started starting from the futility assessment to the shared decision making, you have to have a proper process of documentation, documenting every meeting that you have had with the caregivers, you have had with your extended team of multidisciplinary individuals, and at the same time, whether this decision has been taken with consensus and commitment from all the people that are included, that are involved in this particular process. Then you come on to the seventh step, which is maintaining consistency with the caregivers, where sometimes there are instances where the caregivers would actually slip into a slippery slope where their hopes are raised by some external factors, some kind of maybe a discussion that the caregiver might have had with somebody else who has given some baseless kind of a explanation that the patient is not in that stage, but still curable. So you need to check every time with the family or with the caregivers about the consistency of their decisions. That actually leads you to an explanation of limiting the life-sustaining treatment, because you know that patient is going to go away from us and we need to give our patient the best kind of care. And when we talk about the best kind of care, as we saw in the case of Mr. AB, we need to limit the life-sustaining treatments. Avoid any kind of invasive ventilation, avoid any kind of futile interventions for this patient. And henceforth, the step 8 of this particular pathway is an extremely sensitive step. The documentation will actually go on till you reach the last step of this process. This brings you to the actual process of end of life care, where you need to support the patient throughout by managing his symptoms, managing the pain, managing his spiritual and psychological issues, not only of the patient, but also of the caregivers, trying to bring them to accept the fact that the patient is slowly going away from us. Ultimately, after the death, there has to be a proper, after death care, where sometimes in hospitals, many a times the bodies are just sent to the morgue, and it's being handled very, very insensitively, and it becomes really a very difficult scene to accept. And there's nobody to actually lend a hand, lend a shoulder to the family after the patient passes away. But as a palliative care team, our work just doesn't stop after the death. It extends to an after death care, going on to a bereavement support. And if it's a child, or if we have come to know that it's going to be a complex bereavement, we need to support the patient for even more, the patient's caregivers for even more. And then when you have actually completed your bereavement, you need to review the whole care process that you have started for this particular patient from step 1 till step 12. And this is a complete proper plan of how to deliver the best end of life care for our terminal patients. So I'll not go into very details, but I would like to point out, important steps, important designates, where you will need to perhaps answer yourself. You will need to give answers to your colleagues. You will need to give explanations to your patients and caregivers also. So what are the medically futile conditions where end of life care is appropriate? Basically, if the patient has an end stage pulmonary, cardiac, renal, or hepatic disease, severe sepsis, refractory illnesses with organ dysfunctions, unresponsive to a treatment, patient is in coma, which is non-reversible, there is a chronic severe neurological condition with advanced cognitive or functional impairment with little or no prospects for improvement. There is a progressive metastatic cancer where all treatment options have failed, post cardiorespiratory arrest with prolonged poor neurological status, any other comparable clinical situation coupled with a physician prediction of low probability of survival. So these are situations, these are medically futile conditions where we will need to adopt end of life care. as the appropriate means to go ahead. So why do we want to assess or recognize medical futility? And the important points being that recognizing medical futility and the dying process is the first step in providing end-of-life care. If you fail to recognize medical futility, if you fail to touch upon the start of the dying process, you will never be able to provide the end-of-life care. It is a reasonable prediction of mortality, and it is essential to identify the patients in whom end-of-life care discussions can begin. If you have decided, if you have recognized medical futility, you have recognized the dying process, you have to start with discussions first with the patient and with the caregivers. So these should be based on the physician's objective and subjective assessment of the medical futility and the dying process. So these are the three important reasons as to why we need to assess and recognize medical futility. So what are actually the alternative options that are available instead of acute medical management that is generally seen in many apex hospitals and nursing homes also? So when the fully informed, capable patients or the family chooses to opt for the overall treatment goal of comfort care only option, the physician has to explicitly communicate the standard modalities of life-limiting and prolonging interventions. So you will need to give them that in a platter, and that would include withholding of life support or non-escalation, withdrawal of life support if the patient is already on a life support, and symptom management or comfort measures at the end of life. So these are the alternate modalities of end of life care. Little bit about how to discuss various modalities of limitation of life sustaining treatment, because this is the point where many questions will be asked, many eyebrows will be raised. So the common modalities involve not initiating new therapies that are aimed at care, are not initiating therapies that the withholding, withdrawing, or weaning from mechanical ventilation, the question of usage of vasopressors, some form of renal replacement therapy, other therapeutic medications, the question of giving more and more total parenteral nutrition, and also extubation. And before proceeding with the end-of-life care measures, it is always pertinent to prepare your own staff, the family members, and the patient, if at all he is capable at that point of time, and the patient's environment. So this is how you have to discuss the various modalities of limiting the life-sustaining treatment. Now, how does palliative care at the end of life differs from that of the regular palliative care that we provide? So importantly, the relief of end of life symptoms, basically, intractable pain, dyspnea, secretions at the last 48 hours. You have to review the existing care protocols, basically that deals with the medical and nursing teams. Review the medication charts and stop unnecessary medications that are already going on. Counseling regarding optimal hydration and food intake. And it doesn't mean that, you'll keep on hydrating the patient even if it doesn't have any evidence. Last but not the least, need to psychologically support the patient, the family, the caregivers with a special emphasis on meeting family requests, which are, in and around, circle in and around the religious, spiritual, or cultural values of the patient. So this is how the end of life palliative care differs from that of regular palliative care. So the principles of end of life symptom management would be, once daily symptom assessment, which is mandatory, anticipation of symptoms. You should always be willing to write an anticipatory prescription, basically for those patients who had episodes of pain in the past, have had, malfunctions of their systems, and at the same time ensure the access and availability of essential medications for symptom control. Careful evaluation of symptoms and medications dose must be adjusted accordingly, according to the symptoms that are coming. You need to frequently reassess the response to medication. And once you see that, one of these medications are actually going on for no reason, you need to stop that. You must also give SOS or PRN orders to cover the intermittent symptoms and the breakthrough events of persistent symptoms. Rapid readjustment of doses of background or round-the-clock medication must be always taken into consideration. The routes of drug delivery must always be the most reliable, the least invasive, and the most convenient for the patient and not for the medical staff. You need to empower or educate the family and caregivers in the whole care process, because if the patient or the family decides to go home and have the end of life care done at the home setup, the empowerment and education of the family that you have given would be the most important ones. You must consider palliative sedation when the symptoms become refractory. So how do we recognize the dying process, and how do we actually predict death that is coming? Unfortunately, doctors are very poor in predicting deaths because of the fact that they are very, very optimistic about the patient's condition. As doctors, we are also hopeful, filled with hope that our interventions are actually going to help the patient come back to normalcy. But that doesn't happen. And we are at the forefront of accepting the end of life care, accepting the futility of interventions, accepting the fact that the patient is going to die. In cancer, the cancer trajectory is typically a gradual deterioration, which finally leads to deaths, and so we don't actually expect a sudden catastrophic event to happen, which is actually very rare. It might be there in certain conditions, like a tumor compressing the carotid artery, which has actually given way and the patient has died of massive hemorrhage. Accurate prognostication is more or less difficult, but then since we need to advise them on the given time, because this is a question that has always been faced by doctors, it's always advisable to give the time in terms of days, weeks, and months. Okay, so once you see that the patient is deteriorating over months, you say that he has months to live. When he is deteriorating over weeks, you say that he has weeks to live. And when he is deteriorating over days and hours, you say that his deterioration, he has just few days to live. Um, if you see there a sudden deterioration in this particular trajectory, you must take the indication that there are certain reversible causes like infection, hyperglycemia, changes in medications. And if we correct them, the patient might actually revert back to uh, uh, the setup trajectory of cancer, of deterioration. Diagnosing the dying phase is also very important. And there are definitely signs and symptoms of imminent death. Uh, the patient is cachectic, he has a gaunt face, profound weakness, he's bedbound, he needs assistance for all the activities. He's decreased or nil intake of food and fluids. Definitely a decrease in the urine output. Peripheries are cool and clammy. They may actually get mottled and gray, which is very, very, common for cancer patients. Mouth is dry, conjunctiva may also be dry. A weak pulse and a falling BP, a shallow and a slow inspiration actually leading to the Chine-Stokes breathing pattern, disorientation of the patient to time, place, and person, and slow, decreased spontaneous verbalization, less of interactions from the patient side, leading to a loss of consciousness. So these are the signs and symptoms that death is imminent. The International Collaborative for Best Care of the Dying Person have actually, laid down a beautiful chart where, they actually tick mark all these goals, goal A to goal Q, about the patient. And it's a very detailed one. You can actually adopt it to your own settings and try to fill them up. And they do it every 4 hours for a end of life care patient. So I come to the common symptoms in the last 48 hours. Basically, we are challenged with pain, breathlessness, urinary dysfunction, nausea and vomiting, death rattle, and certain emergencies like acute stridor, convulsions, terminal restlessness or agitation, and hemorrhage. So coming one by one, 3/4 of all our dying patients will have pain, and those would actually require strong opioids. The causes of pain being progression of the disease, change in the route of drug administration, pathological fracture, constipation or urine retention, pressure sores, mouth ulcers, etc. And you need to assess the pain essentially by facial expression if the patient is unconscious or patient is comatose. Basically, the routes of drug administration are preferably the subcutaneous, intravenous, patches, or per rectal. Sometimes we also opt for the sublingual, but not the oral. If the patient is on a Ryle's tube, we would actually prefer to take out the Ryle's tube and use our medications through these routes only. Pain medications need to be revised and changed if needed. For severe pain, the strong opioid of choice is morphine, which is given, started for at 5 milligrams subcutaneously or 1 milligrams slow IV. If you consider, a rescue doses, which are needed for more than 3 episodes per day, you have to take help of the continuous subcutaneous infusion of morphine. But then be careful about the side effects and the adverse effects. Basically, the management of pain actually becomes aggressive at the end of life, at the last 48 hours. But the principles of pain management remains the same that you've already gone through in your previous classes. Breathlessness is another symptom which is extremely, difficult to see, both for the patient, the caregivers, and the medical team also. So, 17 to 47% of our patients experience dyspnea in their terminal phases. The causes being extensive lung mets or lymphangitis carcinomatosa, anxiety or panic, chest infection, pleural effusion, pericardial effusion, anemia, etc. So we need to correct the correctable causes if we see any of these, or otherwise, morphine is the drug of choice for uncontrolled dyspnea. You would actually want to argue, you might want to argue about respiratory depression, but this is not so. For opioid naive patients, you can actually start with 1.25, escalate it up to 2.5 milligrams of subcutaneous morphine injection. And this can be actually increased or escalated by 25% with an increase in the dyspnea, because we know that dyspnea will not be cured by use of morphine. The feeling of dyspnea will be reduced. So for patients who are already on morphine, for breathlessness, you have to increase the dose by 25%. If there are associated panic attacks because of dyspnea, the drug of choice is either midazolam or lorazepam, sublingual or intravenous, in the doses of 1.5 milligrams or less. Unfortunately, the role of oxygen is very, very doubtful. There is actually no evidence that oxygen helps, but there are people, or it has been used quite extensively, which should not be done. Urinary dysfunction is another problem. It generally occurs due to progressive weakness and tiredness. Patient is actually not able to control the dysfunction. We have to consider the wishes of the patient first before we think about an indwelling Foley catheter or a condom catheter. Pads are generally, not preferred because, they are the culprits of causing a lot of rashes and pressure sores also. So if urine retention goes on unnoticed for this patient, the patient may land up in delirium and become very much agitated. Nausea and vomiting are, are very, very common accompaniment during the end of life. And the underlying principle of management is always treating the cause. If it is drug-induced, we need to use haloperidol at a dose of 1.5 to 3 milligrams subcutaneously. We prefer to use subcutaneous injections in cachexia-induced cancer patients because of the fact that there is a lot of subcutaneous space because of the loss of subcutaneous fat. You can also use metoclopramide, 10 milligrams subcutaneous, if the cause is metabolic. Again, haloperidol. Gastric irritation, you need to use pantoprazole or omeprazole and stop the drugs that are actually causing it. If there are brain mets and the nausea, vomiting is due to brain mets, definitely dexamethasone. Renal failure will actually, bring in a lower dose of opioids, and also consider reversal of opioids. If you are using morphine and, you will actually need to convert morphine to, change it to fentanyl. And then haloperidol at that point of time is also going to help. Many people are disturbed because of death rattles. The secretions that are quite seen in almost 25 to 92% of our terminal patients. It's kind of a gurgling or bubbling noise that occurs due to secretions settling at the back of the throat. Patient is actually too weak to swallow it or expectorate it. And that's the reason why, with every inspiration, there is a gurgling or bubbling noise. It is extremely distressing for everyone, including medical professionals. So once you see that the patient has actually slipped into, the last 48 hours of his life, a prophylactic treatment is always preferable. So general measures like repositioning and explanation to the patient relatives that the patient is actually not choking to death generally help a lot because they would actually take part in repositioning the patient. Any of these following drugs are equally effective in controlling secretions. Atropine at the dose of 0.6 milligrams sublingually or subcutaneously, Q6H and PRN. Glycopyrronium bromide can also be used 0.2 milligrams subcutaneously. Hyoscine butyl bromide, commonly known as Buscopan, is also used and is really very effective, because if you do not get glycopyrronium or atropine, hyoscine is actually readily available in every center, and you can use it 20 milligrams subcutaneously and repeat it every 6 hours. In a palliative care setting, we generally do not recommend suction. Okay, so because we know that we will be able to control death rattles effectively, so we do not actually use suctioning. These are emergencies at the end of life. You can actually go through it. If it is a stridor, the cause may be hemorrhage into a tumor pressing onto the trachea, and any cause of tracheal compression would lead to acute stridor. The management is definitely immediate sedation by using 5 to 10 milligrams of injection midazolam, IV or subcutaneous. You can also alternately use diazepam solution, which can be given rectally. Basically, children are being given rectal application of diazepam solution to control stridor. Convulsions generally are seen with those with a previous history of seizure or a post-neurosurgery patient with a primary or secondary cerebral malignancy, those patients with a sudden withdrawal of long-term anticonvulsants. So again, midazolam is the drug of choice at a dose of 5 to 10 milligrams subcutaneously and via a syringe driver. Anticonvulsants generally need to be restarted for these patients, even at the last 48 hours of life. Restlessness or agitation is seen in almost 40% of our patients, and the main causes being presence of brain mets, a history of epilepsy, metastasis, encephalopathy, electrolyte imbalance, urinary retention, constipation, infection, and some few side effects of certain drugs. So you can actually control end of life restlessness, terminal restlessness very, very effectively by correcting the correctable causes. You need to treat the identifiable causes and consider sedation if the restlessness still goes on. And the drug of choice is again midazolam at a dose of 10 to 100 milligrams every 24 hours. Haloperidol is a frequent accompaniment of midazolam at the rate of 2.5 to 5 milligrams subcutaneous or IV. And it is extremely, extremely effective in relieving confusions, controlling delirium associated with restlessness. Hemorrhage, as I said, is may not be seen, but then it can actually occur due to a tumor compressing a large artery. And unfortunately, we are not really in a position to do anything at that point of time, because patient actually dies because of acute hemorrhage. You have to reassure the caregivers, prepare the family regarding the impending death because of the hemorrhage. In our wards, we use green towels instead of the white ones to mask the reddening, frightening sight of hemorrhage. Maintain a fluid balance and other, general measures that can be taken at that point of time. Little bit about clinically assisted nutrition and hydration, because this is one important question you will be faced with, because every family will actually demand some bit of nutrition, some bit of hydration at the end of life. So clinically assisted or artificial hydration will not be of benefit, and decisions about their use should be individualized and made in the patient's best interest. Symptoms of thirst or dry mouth, they are often due to mouth breathing or medication, and even due to oxygen therapy, continuous oxygen therapy. So there has to be a good mouth care, a frequent wetting of mouth that is going to alleviate the symptoms of thirst. If the clinically assisted artificial hydration or nutritional support is in place, then you need to review the rate, the volume, or the route according to individual needs, such that these complications related to overt hydration and parenteral nutrition at end of life is avoided. Also consider IV antibiotics should be actually rationalized and need to have a judicious prescription, because it may not confer any additional benefit during end of life care. Very importantly, after you have done everything for this patient, you have corrected the correctables, you have tried to manage the pain, you have tried to manage the symptoms, but still there are situations you will be faced with certain intractable symptoms. Basically, uncontrolled pain, uncontrolled dyspnea, and intolerable symptoms. So we need to go for something called palliative sedation, and it is defined as medication-induced sedation that is administered without intending to cause death, utilizing a non-opioid drug to control intolerable symptoms that are refractory to conventional treatment in patients with advanced and incurable disease whose death is imminent or is expected in hours or days. So the message that I want to give you from this particular definition, that we do not use morphine or fentanyl to induce palliative sedation. Please do not, be in this in that particular confusion that if we do use palliative sedation, we are going to use morphine. It is not like. It has to be other drugs which are, the common conditions where palliative sedation is considered is intractable pain, intractable dyspnea. And we use drugs like midazolam and haloperidol to induce palliative sedation. So when do we consider palliative sedation? When the symptoms are refractory to pharmacological and non-pharmacological options, death is going to be imminent in days or weeks. There are additional treatments which are unlikely to bring relief. Aggressive palliative treatment has failed to control the symptoms. The goal is relief of distress of symptom, and there is not enough time to try a potential non-sedative approach for impending death. So this is about palliative sedation, and this brings us to, again, the structure that we have been following. Now, mainly, how do the primary oncology team actually, show their empathy or communicate the process of end of life care to bring about a good death to this patient? So I will actually.
There are two questions in the chat box right now. One is by Dr. Gobikishan. He has asked, ma'am, in certain patients we see continuous fever in spite of giving paracetamol, antibiotics, or sponging. It doesn't come down, and the bystanders force us to do something. What can be done in this situation? That's one question. And another one by Dr. Sunish that says, why not morphine for palliative sedation?
Yeah.
These are the questions, ma'am.
Okay. So question one, for if continuous fevers, you definitely will have to look into the question of infection. There might be infection because you are actually giving paracetamol or antipyretics, you're doing the sponging, it's not coming down, that you need to definitely investigate on those lines. Sometimes continuous fevers also actually point towards, in an intractable symptom, just like, the question of dyspnea or question of pain. So you might as well want to consider sedation in this kind of patients. So that is one. Secondly, why not morphine for palliative sedation? So morphine is, induces sedation by virtue of inducing complete pain management. Okay. If you have pain and this pain is actually responsive to opioids, strong opioids like morphine or fentanyl, the patient actually gets relief of pain and thereby goes to sleep. It is not because the patient is sleeping because morphine is inducing sleeping. Okay. Drowsiness is actually a side effect of morphine, and we do not want to have the side effect. All right. So for these patients, to induce sedation, which is intended to relieve the suffering of intractable pain or intractable breathlessness or any other intractable symptom, we are not going to use morphine at all and induce drowsiness into the patient. We want to induce sedation and not drowsiness. There is a vast difference between drowsiness and sedation. I hope I'm able to answer this question.
Yes, ma'am. Thank you, ma'am. Thank you for the answer. Are there more questions?
One doubt. Ma'am,
Carry on, doctor.
Morphine usually produces an euphoria, no, ma'am. Is that good for a patient who is nearing his death?
Well, there are euphoria and all the effects of morphine or opioids are actually dose responsive. Okay. So at certain doses, the morphine will cause euphoria. At certain doses, morphine will induce drowsiness. At certain doses, morphine will induce pain management. Okay. So our intention is induce euphoria for our patients because there are dying patients and we need to relieve them of their suffering. That's why I'm not going to use morphine.
Okay. Ma'am.
Are there any more questions? Thank you so much, ma'am, for the wonderful presentation and clearing the doubts. This is a very useful topic, especially for all of us. And this whole course was a very good learning experience for all of us, including myself. Thank you so much, ma'am. If there are no more questions, can we find up graduation?
Yes, sir. Dr. Sridevi has joined. Thank you, Dr. Sanghamitra, for that session. Dr. Sridevi, any closing messages?
Thank you so much. I am so sorry. I was not a part of this session because Dr. Manu was leading it. It didn't need me actually. So this is my first appearance to this. But thank you, Sanghamitra. I could listen to the last part. And thank you so much for taking such an important session. And this is the last session for this batch.
Yeah.
I'd like to, I mean, I'm not spending too much time and wasting too much time from your session, but if there are any critical feedbacks that we need to consider for next batch, that will be great to know. If there are any changes that you think should have been done or any sessions that you think should have been included, any critical feedback, we are happy to take it. And my special thanks to Dr. Manu for taking up the whole program. So I really didn't know how it went. Only Rajlakshmi and Dr. Manu knows about it. And thank you so much for doing it in between your work schedule and agreeing for taking up such a, because it's like every week you have to be engaged for 1.5 hours. So that's, I know how it feels after the work. So thank you so much for doing this for us. If there are any critical feedbacks, we are happy to do it, hear it. And I mean, if there is anything for now, we are happy. Or you can email it to us or send by WhatsApp.